Okay, so this lecture is on the running assessment tool and how to actually conduct it when doing a running analysis. Okay, so what today's presentation is the clinical application. What it is not is the supporting evidence for it. I'm happy to provide this supporting evidence beyond the scope of today's lecture, but today is specifically about the clinical application and learning the skill of implementing the running assessment tool, or the RAT.
So why do we need to have a model for return to play or return to sport? I think it's important to clarify the process for the clinicians when determining when an athlete is ready to go back. It's been suggested that with a previous injury, you're about a fourfold increase in risk of re-injury based off of what this paper is. Certainly there's a lot of other statistics out there talking about other increased risks depending on what type of injury you had if you return before a specific timeline. I think we commonly see that with the ACLs that we work with. I think it also provides structure and helps decrease the controversy. Like I mentioned previously, it's a little bit of an art, a little bit of subjectivity to it, or this can outline someone's decision making a little bit better, especially if they implement it. And it allows assistance to the physician, the PT, or the athletic trainer, whoever is going to be the ones to make that call. Certainly, I've worked with PTs or with physicians who have said, yeah, you're good on my end, only checking with me as you need to. You're clear when your PT says you're clear. And obviously other instances, the physician can also be the one who says, all right, when I say it, you're good. But I've been put in that spot a few times, and I've found this to be helpful. Also identifies the gaps in practice where the evidence is lacking and helps give us a framework where we can. So how do we define return to play? What does it mean? Creighton et al. Suggested that it's a medical clearance of an athlete for full participation in sport without restriction, meaning strength and conditioning, practice, and competition. However, we do see that sometimes people are cleared to practice without being cleared to play yet. And it's a rational model. It talks about the advantages versus disadvantage of allowing someone to compete. There's always going to be an issue or a few things to take into consideration if you allow an athlete to compete or if you restrict them from competing. And essentially, you're making the decision that affects someone else significantly. And so if you choose to let someone go in and play, if they get re-injured, then you certainly could be liable for that. However, on the flip side, if you don't let someone and they lose out on certain things like financial incentives, endorsements, scholarship, you also could be held liable. And so this basically proposed a three-step process model for allowing individual practitioners to make that return to sport or return to play decision. It took into consideration three things: health status of the performer, what was the participation risk, and what was decision modifications that needed to be made. This is their big little infographic that they recommended. You can see the three different steps. We're about to go through those in detail, but essentially it talks about medical factors, the sport risk modifiers, and decision modifiers before ultimately leading to a return to play decision. So step one speaks about evaluation of health status. Basically what it is was assessing the athlete's recovery. It's including biologically, psychologically, and functionally. Certainly biologically, if it's within the time period that you would expect a certain soft tissue or bony structure to be healed. Psychologically, is that person ready to go back, or have they developed a kinesiophobia where they're afraid to go out and perform those movements? Functionally, have they atrophied, or are they still missing range of motion? Can they not perform what they need to perform despite the time having passed? And also lets us evaluate how much healing has actually occurred or how close to normal the tissue is. So a few things to take in consideration. Certainly, here's a long list of things. It's basically like a relative exam, and so you go through the different things, and we break them down, and it all goes, kind of like what we interview people with every day. And so we have, history or patient demographics. What's the sex, what's the age, what's the influence, and maybe hormonal and age-related factors that could influence tissue healing. Symptoms, is there pain, is there stiffness, is there instability, what are the signs? Is there swelling, is there effusion, what is the range of motion, what's the strength, can we measure the strength? What's the stability, is it still tender? Lab testing, we can always utilize that in conjunction with these things, like X-ray, MRI, CT scan, bone scan, or ultrasounds. Functional testing, I think, is great. Looking at certain exercise maneuvers that simulate the sport-specific actions, putting them in a controlled environment and closed environment before we let them out into some unnecessary open environments. That all includes some of the things from previously. So like the strength, the range of motion, proprioceptive, endurance, and competence. In functional testing, we should mimic the forces and stresses as best we can that will be experienced by these athletes in a competitive situation. Now, that can be hard because you're probably not going to be lining up one-on-one with your defensive lineman and doing run blocking. You're probably not going in with a basketball player and getting down and dirty and in the paint to try to get a rebound. You try to do the best you can. Psychological state, what's the readiness or confidence of that person? Like I mentioned before, is there kinesiophobia? Is someone afraid to move? Those can all be associated with a higher risk of re-injury and also negatively affect their performance. And then potential seriousness. What's the particular tissue that's injured? How badly is it injured? And what's the propensity for healing here? Consider a concussion versus ankle sprain. Certainly also think about the long term versus short term. What is the the ripple effect that this injury is going to have down the line. Then once you take all those things into consideration from the evaluating the health risk, you move into step 2, which is the evaluation of participation of risk. So sport risk modifiers. That's where you really want to evaluate the risk factors in the sport that have the capacity to substantially increase or decrease the participation risk for a given health status. Certainly some things to take in consideration are the participation is what type of sport is this? What's the risk of an acute injury in a higher collision sport like football, rugby, velocity sports like alpine skiing versus a contact sport like basketball? And then, what's the risk of it in a non-contact sport like swimming? So we tend to see that, acute injuries are higher in those, higher velocity, higher collision based sports rather than those non-contact sports. You also take in consideration what position is being played. So what is this person, what's the task that this person has to endure? Is this an AC separation in a quarterback or a kicker? That can obviously be something very impactful or not so much. What's the limb that's involved? Think of a baseball pitcher. Is this his throwing or non-throwing arm? And what's the competitive level? We tend to see greater size, speed, and strength, gradually meaning greater forces and stresses, relatively higher levels of competition, higher amount of force made, potentially higher risk. And then what's your ability to protect the pathologic tissue? Are you able to utilize certain things like taping, bracing, splinting, or padding to help reduce the risk or the force that goes through that joint or that area? It can sometimes be subject to rules and regulations based off of what the sport will allow. But if you can provide some protective area to it, then that might be something to take into consideration. And then what is the acceptable level of risk? This has to occur in the context of decision modifiers. Is this going to be a lifelong effect? How big is this ripple? It's argued that the health of the athlete should be the only concern because all activity is associated with risk. That leads you into step 3, decision modifications. And it can't be used without knowing the participation risks, so the things that we discussed earlier. The things that go into the consideration of it are timing and portion of the season that they're in. So is this in the off season or is this in the playoffs? Is the short-term or long-term risk for disability greater or less? You have to take into consideration pressure from the athlete. The clinician makes the legal decision, but the athlete, are they involved in the decision? What if you have someone who has a concussion and they want to go back in? Do you let them? I think the answer is no, because pressure from an athlete who wants to compete, go out and go. They could potentially, be too in the moment and make an emotional choice, and ultimately it could be something that has a large effect on them later down the road. You can also have pressure from the coaches and the family, and that would be external pressure. So certainly with a coach, if you tell them that their star player can't go in, or if he's injured and he has to come out, if that significantly impacts the game, then that's a potential issue for that coach. What if job security is on the line? For parents, what if there's a potential scholarship that could save these parents hundreds of thousands of dollars based off of their child's ability to compete? Also, things from agents like contract offers, endorsements. And so one thing to take into consideration as an example is DeMarcus Cousins, who, coming back from an Achilles rupture, had a distal quad rupture in the playoffs of this past year's NBA playoffs, who came back for the finals and sure enough had another injury after the season for his ACL. Something to take into consideration too, or can you mask the injury? So there's some things out there like cortisone injections, local anesthetics, and analgesics that are often used, more so in the college and professional level. However, those can potentially increase the risk of worsening the pathology and prolonging the disability. Certainly there are conflicts of interest. It all speaks about the clinicians also have an obligation to the team if they're a paid employee. What do you do when a team's best interest and an athlete's best aren't aligned? And then fear of litigation. I think this is one thing that a lot of people have concern about, obviously, but clinicians can be sued for damage that may result when an athlete is injured after a decision to allow them to return to play if it's deemed too early, or if the athlete is deemed inappropriately restricted from return to play and has financial loss. So something that recently happened that I was exposed to was this case, and I thought this would be a good discussion point. And so you had two athletes. They both sustained acute ACL ruptures. It was a high school basketball athlete who was a sophomore, and he was in the December part of the season, so the season just ramping up. It was a basketball tournament. And the other was an Olympic karate performer who was a Pan American champion. He had done well, and he made it all the way to the final round, and he was one match away from making the Olympic trials. And sustained, unfortunately, an ACL rupture. And so both of those two, they were both kind of bouncing around and, were kind of wondering if they could go. Both of them had, effusions and, subtle loss of motion in their flexion extension. Noted no instability with normal activities, however, really ramping up. Sometimes would feel a little bit unstable, however, really wanted to compete. And ultimately, decision certainly was taken to consideration for both of them. The high school one, I think, was a pretty cut dry, easy decision. There wasn't a whole lot for this athlete to gain by going out and competing. Certainly, the things that could have happened outweighed the positive. There was no scholarship. This wasn't for national championship or world championship. Really nothing that, at least in the physician's and the family's mind, was worth allowing this athlete to go out and perform. On the other side of that, this Olympic trials match for this karate performer, to him, this was his world championship. I mean, it was one match away from him potentially making the Olympics and then having a chance to go out and compete for his country, which was something he had trained for almost 20 years. And to him, it was a pretty cut and dry answer what he wanted to do. He was going to go out and he was going to try to do his absolute best. Certainly, he was advised about all the risks, all the things that could have happened had he gone out and competed, but ultimately he kind of sat down and said, this would be worth it. And so he went out and competed it, and unfortunately he had an instability episode at the very end of the match, and it cost him a couple points, and he ended up losing that spot. And so I thought those were very interesting examples of the contextual factors making the decision for, is this athlete ready to perform or not?
Okay, great. And now we'll be moving on to the expected timelines for return to sport, where we'll discuss the tissue healing timelines, the functional performance timelines, and then the documented return to sport timelines that currently exist. So recognizing that there's the one timeline where the whatever tissues otherwise involved in the surgical procedure or the injury needs sufficient time to have its adequate integrity and capacity to be able to tolerate athletic-based training. But then there's also the functional timeline as far as the athlete actually being able to regain their strength, range of motion, etc., which is a bit more variable, yet there are still predictive components that we can share with this. All right, so tissue healing and functional performance time. All right, so this diagram that is put together by Axe and Schneider-Mackler in 2005 from the orthopedic section. You'll see it crop up in a number of different monographs put out by the orthopedic section as you peruse through these during even. Again, here's a high-level summary, just a different way of looking at it as far as the different types of tissues. So you have the contractile tissues in blue and the non-contractile tissues in red there. So one resource that I've put together that has been helpful for my own predictions of these injuries, whether they be operative or non-operative, is the tissue healing timeline in the physical performance Excel spreadsheet. And if you haven't already used this or I haven't shared it with you, it is in the shared drive, and you can see the folder cascade outlined here. All right, and then you would just click on the performance tissue healing timeline. Okay, you can notice that at the bottom of that Excel spreadsheet that there would be different tabs. Tissue healing timeline is the one that you want. Okay, so this is an Excel calculator that will help you. And then really what it allows you to do is you would put in the respective date of the procedure, and then you would put in the date of whenever you're accessing it. So I populated an example here for you. So say 11/2020. And then, so you can either type in the date or you can use the shortcut of hitting Control plus semicolon. And once you do this, it will populate the days, weeks, months, how far out the patient currently is. And then it will also populate the predicted tissue healing timelines as shown in the chart there. Depending on, again, contractile tissue, the extent of the injury, and then the variability as far as the minimum and the maximum amount of time
there. Grade 1, 2, and 3.
that you can
etc.,
predict
and/or the bones
that
such
tissue to be
fracture,
healed.
articular cartilage, and/or meniscus. And then the
Okay, additionally is ligamentous injury and the remodeling of the ligament. There was a great article that was published by Scheffler et al. In 2015 where they looked. All right, let's talk about the functional timelines now. So the current practice of time-based goals often do not reflect the athlete's functional ability at the time the time-based goals are reached, i.e., just because an athlete is 2 months post-operative or like post-injury of a lateral ankle sprain doesn't necessarily mean that their functional ability is regained at that time, or their prior level of function is what it was, and that they're ready for returning to sport. So if the ability of returning to sport successfully is related not to the healing timeline. So when you look at the current literature, specifically for ACLR, because we know that there's a multitude and a plethora of research that has been done around this injury, post-ACLR is indicated that a high proportion of athletes do not return to the same level of sport, have increased risk of re-injury, and have increased risk of osteoarthritis at not only the tibial femoral joint, but also at the patellofemoral joint. Okay, so we've covered the tissue heal, at least defined what is the tissue healing timelines and the functional performance timelines. What we also need to consider is the documented return to sport timelines. Like, what are the current expectations based off different surgical procedures or injuries? Okay, so a recent review by Vasta et al. Looked at the top orthopedic sports medicine procedures. So when we're considering the lower quarter and the surgical procedures that we'll see for each of the given major body regions. So when we're looking at return to sport timeline summary for the lumbar spine, these are expected when time points at which athletes will return to sport, and this again gives lumbar spine continued. So when we're looking at the actual return to play, so 82% of individuals who undergo surgery for. Okay, and these slides again are predominantly for your reference, and they summarize not only the expected time point at which people are returning to sport, not only from a tissue healing standpoint, but also from a functional standpoint, and then when the literature has offered the percentile of return to play. All right, looking at ACL reconstruction and PCL reconstruction, that there's going to be quite a spectrum as far as the percentiles that are reported for those that are returning to play, and also considering what does it mean to simply just return to play versus return to their prior level of performance or their prior level of function. And so when you talk about returning to play or returning to participation per se, that you're going to have higher rates, 56 to 83%. But if you're really looking at those individuals that are returning to the competitive level that they once were, that there's significantly less numbers here. So as low as 13% and everything up to 69% have been reported for the ACL, and for your PCLs, these consistently don't do as well. And this is, I think, because there's not as much guidance for us with these, and there's consistently more research that has been coming out as far as like the PCL rehabilitation. OCDs of the ankle. So also you can see that depending upon the procedures that are performed, this will inherently determine their time point to return to play. And then
listed out there for you. Is there? All right, and so at least for this pre-lecture content, that concludes this information. Feel free to bring your questions, comments, and feedback, concerns, anything of the like to our discussion section for the live session. Also, feel free to leave comments below within the chat section. Happy to respond to those as well. Next couple slides are just the references, not only for this presentation, but also for the larger live presentation.